it has to be very clear in law. What is the time frame for them to tell us that they've rejected us? And then after that, what is the time frame that a hospital can be able, a clinic, a hospital, or whatever, can be able to appeal? And then even after that, they have to give, in the event that the appeal did not work, we need to, the law has to be able to allow for an appeals board. And the membership of that appeals board should be with an equal representation of both the private hospitals, the public hospitals, faith-based hospitals, and the ministry as well, which is now the one that they're going to do. And then even that, we also need to be able to make it clear that every facility shall be given access to view their dashboard. Let it be in law.
On the issue of locking out our staff from SHA claims by 9th. Today is 5th. I can guarantee you by 9th, we will not have gotten our disbursement. Our disbursement will come after 9th. By the time we remit, it will be around 17th. We will not remit less money for SHA simply because the date passed. But for the time when they have not been able to get our remittance, our people will be locked out. It is as if we have a date with when we have to get sick. If there's a way we can tell our people don't get sick during this period, then that will be easy. But diseases are there all the time. So why this discrimination? There's national government employees. Are they also being locked out? Of course not. So what arrangement they make? This is blunted discrimination, Chair, without even trying to hide anything.
I think what we need to be able to hit on more is that they involve us in the standardization. Two, they need to be able to tell us how this app is going to work. Because the other danger that is there as well, Mary, they can create an app. How do we know that that app will give preference to other players?
That's the catch. That's what they are doing.
Exactly, because how will we know? So what we need to do is we just need to be able to tell them this way, that we are supporting you, however, bearing in mind that the number of ambulances the county governments own collectively are the majority. We simply want to be involved in one. Let us prepare the standardization manual. So what entails for it to be called an ambulance. Two, the part that you're saying that we're having a platform, before they launch this thing or anything else, because first of all, they said they want to launch it when? Okay. Now this is where the danger is. If they want to launch it by 1st of December, by now they should have already made arrangements and asked for number plates and logbooks from all the county governments. Now if none of you has already been requested for this information, which ambulances are they planning for? Unless there's someone who's already imported these ambulances mysteriously.
Most of the patients will be patients from counties. And therefore, when they control it from Nairobi and license it from Nairobi, it means you can find an ambulance that is worse than the ones we are calling Maternity licensed, which will be too late for you, and there's nothing you can do because you're not the ones who license them. They come and pick your patient. Sometimes maybe you're not there physically to say, no, your people may say, it's better we move because there's no other ambulance available that time. Then they die on the way. It's even better if they were somewhere else. So we should be involved in co-creation so that we have levels, including in that vetting, counties should be involved so that we can also, like the way we have a board, where we have our own representatives, and we also make sure that what is going to operate in your neighborhood, there should also be vetting. Why should ambulances be sent to operate in Mombasa, cleared by Nairobi, and the governor of Mombasa has not been involved in checking the standard as well?
The danger that is going to be there, I can assure you, you know the way the NESP worked, this is what is going to happen. What is going to happen is you'll get a number of people, because they've already made it clear that they're going to now throw it out there that whoever has an ambulance, this is the rate at which we are paying per distress call, per kilometer. Now, if we're not careful, what will end up happening here is county ambulances will now be sent to departments of veterinary and agriculture. I'm proposing that our secretariat with the legal team to immediately come up with amendments to the SHA law. Because once that is law, one, it has to be embedded in law. What is the time frame that they're actually meant to pay? What date are they actually meant to pay? Two, what are the penalties?
And right now what is happening, because at those level of care we are not providing maternity services, we are basically going back to where we are. So skilled delivery basically will drop. Mothers will not go to those facilities because they know where I used to deliver. If I don't deliver to the next facility that is near me, I rather deliver at home. So then that means skilled delivery will basically reduce, and we have already reports on that. The gazetted benefit package also limits maternity services to SHIF, which cannot be used in level 2 facilities. As a result, these facilities have missed out on at least Kenya shilling 2.6 billion as reimbursement from delivery. These primary healthcare facilities are supposed to be getting 10,000 Kenya shillings for every delivery, unlike NHIF, where they used to get 2,500. So as a result of missing out, as a result of the directives, cumulatively, these facilities can be able to miss out around 2.6 billion for only deliveries, because mothers now have to go to the higher level to deliver.
For example, excluding level 2 entries out of maternity is actually one of the worst thing which is actually doing from the Linda Mama, as you said. For counties in rural, the rural counties, in the northern Kenya for that matter, in fact, we invested 70% of our health budget on level 2 entries because of the distance. For example, Mandera is about 260,000 square kilometers. I mean 26,000 square kilometers.
So we come up and draft amendments. There are going to be something that is going to be very, very shaky. The issues that are there is delay in payment. So we have to make it very clear that the same way they're saying that by 7th, by 9th, that there's a cutoff. Our proposal will be that within this period of time, the following 9th or the following 10th or the following 15th, they should have already paid to the facilities. Two, it also has to be very clear in that particular legislation. Because you see, they have a whole thing, the one for the digital health. But there's nowhere that talks about what happens when there's no connectivity. So we have to amend that law to include, I don't want to go to that example, but what is going to happen one day if they decide to shut down the internet? So we need to come up with an amendment to include as well that what happens in the event that for whatever reason there is no internet.